Crystal Chapman Lambert, and I am an associate professor from the University of Alabama at Birmingham. And I would like to introduce this session. So, this session is called Reimagining the Role of the Nursing Workforce in Achieving Ending the HIV Epidemic Goals. So, I have the honor and pleasure of introducing Dr. Vincent Guilamo-Ramos, who is the Dean and Distinguished Professor of the Duke University School of Nursing and Vice Chancellor for Nursing Affairs at Duke University, and the founding director of the Center for Latino Adolescent and Family Health at Duke. Dr. Ramos is a nurse practitioner, actually dual certified nurse practitioner, who is widely regarded as an expert, scholar, and leader in adolescent and young adult sexual and reproductive health promotion and the social determinants of health. His research has been funded by the NIH, CDC, and HRSA, and focuses on the role of families in promoting adolescent and young adult health among Latinos in other underserved communities. Most recently, he has designed a nurse-led and family-based approach to increase COVID-19 testing, vaccine uptake, and overall household capacity for COVID-19 mitigation in medically and socially economic underserved communities. Dr. Ramos currently serves as a member of the Presidential Advisory Council on HIV/AIDS, the HHS panel of antiretroviral guidelines for adults and adolescents, and the CDC HRSA Advisory Committee on HIV. So he's very busy. He also serves as the vice chair of the Latino Commission on AIDS Board of Directors and on the board of the HIV Medicine Association. So welcome, Dr. Ramos.
Good morning, guys. It's always a little funny to hear your introduction. I'm Vincent Ramos. I'm really happy to be here today, and I'm excited to be sharing my presentation. Before I start, I just want to take a moment and say that I hadn't been for a little bit at the ANAC conference, and it's just been wonderful to be back. It's fantastic to be with all of you, and it's been a really great conference, right? And so I've learned a ton, and I'm happy to be here. So I'm going to talk about reimagining the HIV workforce. Initially, when I submitted the title of my presentation, I thought that I would focus on just nurses. But as I developed the slides, I realized that I will highlight nurses, but actually it's broader than that. I think we know that it's broader than that. So I want to talk about how can we potentially do some things differently. For this audience, I would argue that much of what I'm going to share, you probably know, but there are a couple of things that I'm going to intentionally highlight. And some of those points are a little bit sensitive, and I hope that we'll have a chance during the Q&A to talk a little bit. And so I think you guys let me know how well I do. There are four things I'm going to do. I'm going to talk about our current context and where we are in terms of ending the HIV epidemic in our country. I think most of us are aware that we've got an EHE initiative, an Ending an HIV/AIDS epidemic initiative in our country. Let's take a look at kind of where we are, what's happening, what our progress has been. What are some of the workforce challenges? I think many of us in this room know, but probably it's been an area that we haven't put enough attention, that we've had inadequate focus. I'm going to talk about 5 strategies of reimagining our workforce. I think many of those things I've heard over the course of the last couple of days, and I think they've been percolating actually well beyond where we are right now in this session. And then I have committed my life to young people, and in particular the Latino community, in supporting sort of how do we respond to HIV/AIDS among Latinos. And so I'm going to use the Latino community as an exemplar. And part of that is a little bit political, because I've been trying for a little while to get more content at HIV/AIDS meetings about the Latino community. So I hope you guys will indulge in that and let me kind of do that. So thank you. So our context. So I think we all know that we've got a federal EHE initiative, and we have these what often are focused on as 4 pillars, but we actually have 5 key strategies. And so we hear a lot about diagnose, protect, treat, and respond. But what we hear less about is the workforce development, and that has been increasingly a challenge, not only for HIV, but I think for public health more broadly, and for our country's ability to respond to a number of infectious disease pandemic events. What's exciting is that in August of 2022, the sort of federal government released a report that is an implementation strategy. And I pulled out a couple of points that sort of speak specifically to workforce, and you can see them listed there. This new implementation plan, it's really a complement to the EHE initiative, but it really talks about increasing workforce diversity, holistic care and treatment provision fundamental to nursing, culturally linguistically appropriate services, again, something that we know, as well as team-based care delivery, and also community recruitment and meaningful engagement. And I think the word meaningful should be there, meaningful community recruitment and engagement. Here's something that I hope all of you will take away from my presentation today. So it's a little bit of bad news, and I hate to be the pessimist, but I do want to point this out. So as I've been looking at the data within my research team, we've been sort of scratching our heads and wondering, well, how is it exactly that we're going to reach our goal, which by 2030, our target is to have 3,000 or fewer new infections in our country? And as I look at the math, if you look here, I've sort of modeled in this slide from 2010 to 2019. And as I look at the numbers, in 2010, about 39,000 new infections annually. And I look at the most recent data, it's about 35,000 new infections. And that line has been going down. So I don't in any way want to suggest that we haven't made progress as a country. Boy, have we made progress. I also think it's an opportunity for us to pause and to critically reflect on to what extent is that line going down at the rate that we need it to go down. As I think about that line, to me it looks like a roller coaster. Like we're at the top of the hill and we need to drop pretty quickly. And that slope is not dropping in any way that we could arguably predict that we are in fact going to meet that target. And you know, from another way of stating it is, if we continue to do what we've been doing for the past 10 years, we're not going to reach our goal. And I think it's time now to start talking about that and being really open and trying to figure out what exactly is going on. So if you look at the numbers, I want to draw our attention. There's a lot going on in this slide, but again, I'm sort of modeling over that same period from 2010 to 2019. And you can see overall, the US had a reduction of roughly 12% in new infections. You can see that the African American Black community had a reduction of 15%, and you can see that the white community had a reduction of 17%. That's great news. That's often what gets reported, and I think it's totally fact-based. But when you start to look at some of the other communities, I'm going to point out my community, the Latino community, what you see is a 6% increase over that period. And what's troublesome about that is that that 6% increase is happening within the context of other groups going down. But let's dig further. Let's dig further. And so I pull out 2 points. These are not all the points, but I pull out 2 points to illustrate why it's important that we look at disaggregated data. So you can see here that young Latino MSM ages 25 to 34, in that same time period, a 67% increase in terms of new infections over that period. If you look at young Black MSM 25 to 34, a 95% increase. So I just want to pause for a second, because a lot of the narrative has been around our successes. Our successes are true, but they're also important health inequities that we need to address. And I think this conference has done a fantastic job in a number of sessions, including Dr. Fields, Dr. Randolph, a number of other speakers that have been highlighting this. And I too want to take this opportunity to highlight this. I've been writing a lot over the last 20 years, and increasingly I'm writing more about what I've coined the invisible epidemic. And I'm continuing to push because I feel like oftentimes the discourse on Latinos tends to focus on issues regarding migration, which are very important, but there are other sort of large health and social welfare issues that Latinos are facing. And one of them is the lack of attention, in my view, to Latinos in the HIV/AIDS response. And you can see here that what was really terrific about this article that we published in the American Journal of Public Health in 2020 is that it did pick up some media attention. And I'm coming back now 2 years later, and I'm just about to submit a paper that is revisiting the Latino invisible epidemic. And I was hoping that when I wrote that paper, that we would be reporting something different. And what we're actually going to be reporting is that things have gotten worse from the time that we actually wrote this paper. And so in that sense, you know, I don't want to take it as a personal failure, but I do feel a strong commitment to wanting to elevate this. And I guess I'm asking for all of us who are leaders in responding to HIV/AIDS in the nursing profession to please keep this in mind, not just for Latinos, but there are some places where we're not doing well and where we actually have been failing. Want to talk about health inequities. I've been also thinking about this a lot, and a lot of my sort of recent lectures over the past year have focused on social determinants of health. And for me, there are three things that I think stand out. One is health status, which speaks specifically to morbidity and mortality. Also, the distribution of health resources you can see here, accessibility, acceptability, issues of availability and quality of services. And then lastly, the social conditions and the circumstances in which people live. And for me, these health inequities or systematic differences, they limit our opportunity and they limit the opportunity of people living with HIV to achieve their optimal health. And when I think about any particular health inequity, I am routinely looking at these three dimensions. So I'm going to illustrate really quickly. So here's an example, just one example of health status. And again, I'm sort of visiting I'm looking at the Latino community, but I have other groups as well that are here. So viral suppression. You can see among persons aged 13 and older living with diagnosed HIV infection, I think the slide is fairly clear. Viral suppression is achieved higher by whites and lower by Latinos and other ethnic and racial minority groups. You can see in terms of mortality, and this speaks to COVID in particular and the impact of COVID among people living with HIV, the percent increase in annual deaths among persons aged 13 years and older who are living with HIV during the COVID pandemic. And so 2020 versus 2019, and you can see the increases. And again, Latinos and African American Blacks, so much higher percents relative to other groups. You can see in the next slide in terms of distribution of health resources, again, an example of how I think about health inequities, particularly within the context of HIV, PrEP. I don't want to be too critical, but I am going to be a little critical. And so I think we've had PrEP for a long, just do it. Don't want to be too critical, but thank you. So about 3 million people globally on PrEP over a decade, 3 million people. And so to me, that is simply not at all acceptable. If you think about the 1 year profits that have been made on PrEP drugs, it's in the billions, and we have 3 million people over a 10-year period. We got to do better, and if you look at this in terms of Latinos, we have 42,000 Latinos who have received a prescription. Nothing in terms of whether or not they've sustained their PrEP, but they received a prescription. Look at the much larger numbers, the close to almost 90% of Latinos, 86.4 to be exact, that actually have indications for PrEP but have not received a prescription. If you look at testing, we know that Latinos are the most likely to be unaware of their HIV status if in fact they are living with HIV. And among Latinos living with HIV, 2 in 5 received no care in 2019. Again, I'm just illustrating. I'm trying to show the larger concepts, and I'm taking advantage of sort of the Latino community as an exemplar. This has become kind of my understanding of what I believe the nursing profession should be pursuing. And I think at Duke, at the school where I happen to be the dean, we are really trying to address this in how we educate and train, how we advocate, everything that we're doing. There have been many large-scale events that have really transformed the health landscape. We often talk about COVID, but it's not just COVID. It's actually all the things that you see here. Climate change, widening inequality in terms of income, behavioral health, addiction, what's happening in the sexual and reproductive health space, Black Lives Matter, Brown Lives Matter, and issues of structural racism, migration. I mean, you can see here that these things have been occurring, at least in my lifetime, and I'm 52 years of age, in a way that has been pretty unprecedented. Some of these things represent chronic, sort of large-scale events that have really been exposed because of COVID. Some of them are new challenges. What's true of all of them is that we know that these large-scale events or social conditions, these SDOH factors, that they represent about 80% of the variability in a given health outcome. And yet, I'm just gonna come clean as a dean of a school of nursing, one of the really terrific schools of nursing, if I can say that. And I'm going to say that and what I'm going to say next will help you to qualify that I wasn't being arrogant. And yet, I don't think that as a great school of nursing, and I want you guys to reflect in terms of where you are and where you were trained, was there adequate attention placed on what you see on this slide? Was the clinical training that we received sufficient to really formally consider how do we take these factors into consideration and better respond to care? And I think that's something that has become both a professional and a personal mission for me. And so I hope this makes sense. There are three things that I think are important here in terms of these large-scale events or social determinants. One, there are sort of new challenges, and it would be remiss if I didn't mention Hurricane Ian. I saw on the news this morning that today is the last day for individuals to sign up for food supplements, and that they're not going to be able to receive those. And right here, in Tampa. And so the impact of the hurricane, it really caused destruction of homes. It led to episodes of homelessness for residents in areas hit by the storm. It created new large-scale challenges for entire segments of the Florida community, and actually, I should mention other parts of our country as well. It exposed chronic inequities, and so again, the people who are most likely to be impacted by whatever the new thing is, monkeypox, COVID, hurricane events, et cetera, that it really shines a light on things that existed prior to that. And so it's not just that new event, but it's actually the inequity that has been enduring and very long term. And I also think this third relationship is one that hasn't been getting a lot of traction, although I did see some sort of glimpses of this. And actually, Dr. Farley was talking about this in his slides yesterday at lunch. What I call synergistic approaches. And synergistic approaches are where you see amplification of negative health outcomes because these large-scale events are coming together. I can give an example from my own state now in North Carolina. There's actually one on the slide, but in North Carolina, we were doing pretty well in terms of opioid overdose deaths prior to COVID. We were seeing that there was a dramatic reduction because the state was responding in ways that made sense. Well, during COVID, it has reversed, and actually the overdose deaths are worse than they had been prior to COVID. And if you look at this, there are disruptions in HIV services in terms of access and delivery that occurred during COVID, and you can see that, or even if we use the hurricane example, during Hurricane Ian, what was it like for people in terms of being able to maintain their PrEP, to maintain their ART, et cetera. And so I think we need to be thinking about these relational forms. And I'm going to say that there's something that's quite striking, at the risk of also being a little provocative. I follow pretty closely when the CDC releases data on sort of new infections and prevalence. And it's noteworthy that the data that normally comes out like in October, it hasn't come out yet for this next year and for the preceding year. And so I'm eagerly watching and waiting for that data because I fear it's going to tell us that we've had a hard time, and that more of what I'm sharing today and my story about us needing to rethink our strategy will be evident from those data. So stay tuned and please look for that data. It's going to be very important data, I suspect. No inside information, it's just my gut instinct. So the cost of health equities, it's not just financial, although I am going to speak to the financial cost, but it's also human. We are nurses and we care deeply about sort of holistic care. And so these inequities, and again, the sort of issues and the disparities in health status, the distribution of health resources, and also these large-scale events that are impacting negative outcomes, they obviously cause excess in terms of morbidity and premature mortality, but they also impact unfulfilled human potential. They don't allow us to thrive and to be our best selves, and they cut our lives short in ways that our country and our communities lose the benefits of what we otherwise would have contributed. They erode the social cohesion in our society. If we are dealing with many large-scale events and we cannot respond, we're overwhelmed, then we are not connected. Think about what happened with COVID. I was living in New York City at the time when COVID hit. I was living in the West Village. And I remember early on coming out of my apartment, and the scariest thing to me was seeing another person that was too close to me. That social cohesion, that connection, that ability to be together and respond is eroded. And we see time and time again in our country, as there are more challenging social conditions, we see more community violence. We see all kinds of indicators that demonstrate that this is an important factor as well. There's excessive bereavement. It's not just the normal bereavement that we would experience in terms of the normal life course, but many people dying and causing a lot of psychological and other forms of of distress in communities. And then there's the unpaid caregiver reliance. And I was recently at a conference, and there was a terrific faculty from NYU, from the School of Nursing, who was talking about caregiver burden, and he showed some data, and I was stunned at how much our healthcare system is relying on family members and significant others, close friends, to care for people with chronic disease, and how much of a burden that can be on the lives of those individuals, and that it's increasing over time more and more. It's not just the human cost, it's the financial cost. There's a great physician, his name is Jay Bott. He's at Deloitte, an accounting firm. And what's really terrific about Deloitte is they just put out a paper in Deloitte Insights that really modeled the financial cost of inequities. And what's really important about this, and what was so striking to me, is that as I was reading the paper, it became really clear that this is not the expense that we would absolutely have to incur. This is expense that if we did something different, if we shifted our focus, and we decided, as the largest segment of the health and public health workforce, nurses and other healthcare providers, that we were going to not allow these inequities to continue, that we were going to do something about morbidity and mortality, that we were going to think about the distribution of our health resources, that we were going to work on improving social conditions, that we would avert costs that are close to $1 trillion by 2040. This is preventable expense. And the basic argument that was coming out of Deloitte, an accounting firm, was that this is not sustainable and that we cannot continue as a country to operate in the same way. In that paper, there was another really sort of eye-awakening and very sobering point that Dr. Bott and colleagues were making. Our population demographics, you can see here these two population pyramids. If you look at persons of color, the base is very wide. And so what that's suggesting is that over time, that sort of base, which represents younger people in our country, that will be in larger part who the US is. Those folks are growing up, and they will represent much more of who we are as a country. What's also true is that if we look at all of the sort of extant scientific data, we know that communities that are disproportionately sort of impacted by health inequities, that oftentimes that is pretty synonymous with communities of color. And so again, it's another way of saying that those costs, both the financial and also the human, that they're going to disproportionately represent and impact groups that will more and more be who we are as a country in the future. It's time to do something. We've got to have a paradigm shift. So as another example of what I just said, here's the Latino community. Latinos are the largest and the youngest minority population in the US. The US Latino population, just again as an exemplar, is projected to nearly double by 2060. You can see that line going up. And there was an interesting paper in the Lancet that I pulled out that said in 2014 that 1 in 5 people in need of HIV prevention services would identify as Latino. But if you look by 2060, 1 in 3 people in need of HIV prevention services will be Latino. So again, the changing demographics of our country. So what does all this mean? It means that if we're going to end the HIV epidemic, and I would say if we're going to end sort of chronic disease in our country and premature mortality, that we need to take action. And I'm asking all of us to continue to take action, but to amplify our voices. We need a paradigm shift. We need to think about things differently, and we need to have those tough conversations about both our successes, but also take a step back and think about where we're not going to meet our EHE goals, and that we need to be very candid, and now is the time to do something different. So I'm going to talk about some of our workforce challenges. That's what ANAC asked me to present on, and so far I haven't said anything about the workforce, and I've sort of put in my own agenda, so hopefully you guys have found that first part interesting. So our workforce, so I'm going to come back to this slide. You know, what was really great about it is that the federal government is thinking about workforce, and this implementation strategy has specific points. I won't read them again, but I think there are 3 areas that many folks who are wiser than myself have identified as being important. I'm simply going to illustrate. And so these 3 areas are not in the implementation plan, but it's sort of me bringing together 2 bodies of work. And so the implementation plan is terrific, but what are we going to do about these 3 areas? The first is scale, reach, and effectiveness. So in terms of scale, workforce challenge number 1, we know that there are more and more people in our country who are living with HIV. it would seem logical that would mean we would need a workforce that can increasingly care for that growing population. We also know that the cohort of people living with HIV in our country is aging. Many folks, and you can see here on the slide, about 54% of people living with HIV by 2030 will be over the age of 50. And what you see on the left-hand side, is if we are not successful at achieving our EHE goals. And I put that there because you guys kind of know what my position is if we continue to do the same. If we do succeed at achieving our EHE goals, the scenario is kind of the same. That's what's on the right-hand side, that we still have sort of increasing numbers of people who will be living with HIV. And in that case, even more so, people will be age 50 and older. In this scenario, 62%. So either way, we need to pay attention closely. Do we have a workforce that can care for all the individuals who will be living with HIV in our country, and also be sort of attentive and responsive and capable of caring for people who are aging? We know that there's been lots of papers published about this, lots of work. One of the ones that I liked a lot was some time ago. There was an HIV specialist, a terrific report that HRSA put out. I understand, and I've seen some preliminary slides, but I haven't seen the full report, that HRSA is going to put out a new sort of update to the HIV workforce. I don't think that the basic point has changed. I think it's remained the same, or in fact, it's probably worsened. We have inadequate workforce to care for people living with HIV in our country. You can see here that there was a great paper in Clinical Infectious Diseases, and our capacity in the HIV workforce was estimated to increase. And so again, it's saying that it was increasing at a rate that was much less than what the actual need was, and so a disconnect. There are three things that are shaping this. One, an aging workforce. I know when I started, I'm 52 now, but when I started in HIV, my first job at Bellevue Hospital, I was very young. I had no gray hair. I have gray hair now, and you know, we're all getting older, and the people who have been my mentors and have really provided great opportunities for me, many of them have retired and are no longer working. And I think it's true that many of them have transitioned to other roles outside of HIV. We have insufficient numbers of people who are selecting sort of HIV as a specialization area. And that's in medicine, that's in nursing, that's in other disciplines. To the best of my knowledge, and I hope I will not offend anyone, Duke is the only school that remains with an HIV specialty program that is really training NPs to sort of work in this domain, and we're going to stick with it. We want to make sure that we have it. We're not giving it up. We're not giving it up. And so what we need is more students to be inspired to pursue HIV as a career. It has been challenging for us to attract students to the program. We need to think about making this a priority, why HIV is a meaningful career in nursing and in other health disciplines. We also know there's been a huge strain on the health care workforce, including nurses, and also other providers, because of COVID. And many people have been redeployed to respond to COVID, or whatever the latest sort of ongoing global or national sort of pandemic is. And so people who work in the HIV space are also being deployed to respond to monkeypox. And when that happens, and there's a good reason, there's necessity for why that happens, it takes away from some of the unfinished work that we have in HIV. And so we got to be mindful of that. Are we borrowing from sort of Peter to pay Paul, or are we really adding new resources and new workforce? So the current Latino HIV workforce, you can see the Latino community in the US population, about 18%, and across all of these different health disciplines, you can see that Latinos are underrepresented. You know, in my view, we need to increase, first and foremost, the number of Latino healthcare professionals. I would say the same if I were presenting an African American or Native American, men in nursing, etc. But let's imagine that we're in the scenario that we currently are. In the absence of our ability to do that, then we've got to make sure that all of us are competent in terms of the care that we provide, and that we can actually deliver culturally competent care. So I'm going to share something that was really troublesome that I commented on the other day. This report came out from CDC, the MMWR. I don't know if you guys saw it. It got a lot of media attention in the papers. And it was really looking at a cohort of Latinos living with HIV. and it talked about discrimination and stigma. And boy, was it really, really sobering. And to be honest, I was quite sad. It said that stigma and health discrimination is common among Latinos who are living with HIV. And so I continued to read the paper and I continued to sort of dive into the content. And what jumped out was something that was really, really quite striking. In terms of forms of HIV healthcare discrimination, a doctor or a nurse not listening to what these patients were saying, and 62% indicating that. I mean, that kind of broke my heart. And so feeling concerned about disclosing one's HIV status, feeling that if you were living with HIV and are Latino, that you would be rejected, and experiencing those things from your healthcare providers. We got to do something about that. We have got to change that. This is the group. If it's not ANAC, no one's going to do it for us. This is the group, okay? And so we've got to speak to our colleagues who are not in ANAC, who are working perhaps with low volume outside of a very specific HIV context, and even in our own context. We've got to think about how we're treating all of our patients and if they're experiencing a setting that is welcoming and that is reducing stigma and discrimination. Latino women, by the way, had the highest reports of stigma. Latino men, the highest reports of discrimination in that study. Here's another important sort of workforce challenge. How are we reaching those that are sort of most in need? And what I love about some of the work that the CDC is doing in terms of their molecular surveillance clusters, I realize that they've been controversial from a community point of view, but I think most of us know that in 2018 and 2019, the CDC identified 136 high transmission clusters. These were networks that had a characteristic that was very important, that HIV was transmitting at a rate that was much faster than what we would anticipate. They represented places where the virus was growing and where it was transmitting to people. These clusters remain very important for intervention, and purportedly from the CDC that they identify these clusters and then there's a response and there's some effort to try to disrupt the transmission and to really think about how they can slow down the progression of disease. And so there are 19 states based on this report that was published. The year is 2021 on my citation. I couldn't see it, but 2021. And so 19 states where 136 high transmission clusters currently were identified. These represent system failures. And so I don't want anyone to think that it's about individuals that are having really risky or involved in things that are facilitating transmission of HIV. This represents our inability as a country to best align our HIV prevention and treatment in those geographic hotspots where these clusters continue to grow. And so, thank you. Thanks, Carol. In that same paper that I'm working on, I've been following these clusters, and I'll give you guys a little bit of a sneak preview. I've been finding some interesting data there. Some of these clusters, I've identified a group that not only, when we fast forward to now, because that was 2018, 2019 when they were reporting these 136 high transmission clusters, I've identified clusters that are growing, that have more individuals. Shocking. Right? So stay tuned for that. Hopefully Carol will invite me back to talk about the clusters. And so when we look at that, 11 out of 19 states where the clusters exist, Latinos are overrepresented in those clusters. And so again, we see overrepresentation. And even in a cluster where Latinos maybe represent 3%, in that particular state, like there's not that many Latinos, less than 3%. So even the ones that are in that state are somehow being impacted by HIV. And so really important that 58% of these high transmission clusters were identified, or this 58% of the states where the transmission clusters were identified, they were overrepresented by Latinos. And so in terms of the third challenge, effectiveness. And so again here, how effective are our service delivery systems? We need to increase our effectiveness. And so I'm just giving another example in terms of viral suppression. So among Latinos newly diagnosed with HIV in 2020, you can see that nearly 1 in 5 were not linked to HIV care within 30 days of diagnosis. And you can also see that nearly 1 in 3 did not achieve viral suppression within 6 months of diagnosis. For me, as I've looked at clinic data from the setting where I work, I'm interested in ongoing sustained viral suppression. And if we're really honest about what's happening with our patients and we look at that data, we probably have segments who maintain their viral suppression for long periods of time, but we see fluctuations. And so in this particular data point that I'm presenting, only 50%, más o menos, 50% of Latinos living with a diagnosed HIV reach sustained viral suppression, which is what we need, which means that again, half are not achieving sustained viral suppression. And I would argue that we need to look at this in terms of whoever the communities are that we're each working with in the settings where we are. Are they achieving sustained viral suppression? So 5 strategies for reimagining the HIV workforce. So some ideas. We've got this traditional approach, and again, I don't know if that's what the folks in this room would believe, but I think outside of this room, I think people do believe in this traditional approach. So a traditional approach is really investment in our current existing models, and our sort of existing models tend to prioritize the role of physicians, and they tend to really identify a very select few prescribers who are then not as as important as physicians, but certainly are part of the traditional approach. We need to reimagine what our HIV workforce looks like. We need to design a workforce that is really candid about the fact that we are not achieving our goals in the EHE, and where are the gaps? Where are the gaps and the failures in the system? And then what does that mean for the kind of workforce that we should be developing? And if we did that, would we look different? And the kinds of people that work on our teams, would they represent different segments of what is truly needed if we are going to end HIV in our country? We need to address scale, reach, and effectiveness, both in prevention and also in treatment. So these are 5 strategies, and I'm going to go through each of these really quickly. And I'm hopeful that I'll leave some time for some questions, and I promise I'll wrap up shortly. So one is broadening definitions of the workforce, this idea of a multidisciplinary, team-based approach, enabling practice at the highest levels. Let's get rid of all of those regulatory barriers that are stopping us from being able to do our jobs. Adopting a decentralized and differentiated model of care, and then not just describing and making referral to social work when we see that there's a social condition, but what is the role of the healthcare team, that disciplinary team, at really effective mitigation of social determinants of health? And so I'm going to talk about those 5 points. So here's our traditional model, and again, I'm sort of illustrating in a way that is intentionally limiting. But I think when I've sat in rooms outside of the nursing space, I've been really shocked at how little there's recognition of all the different kinds of important actors that are shaping the national prevention and treatment response. Often it's infectious disease physicians who are at the table. I sit on the board of the HIV Medical Association, a group that is terrific, that is doing a lot of fantastic work in terms of advancing a number of issues. But I think you guys will support me when I say that it would not be uncommon for me to say, hey, what about nurses? What about the perspective of nurses? And I think they kind of know I'm going to say that at every meeting when I go, but the truth is, why am I still saying that? That should not be what anyone has to say. And so it's not just about ID physicians, it's not just about nurse practitioners who provide HIV specialty care, and it's not just about physician assistants who provide HIV specialty care. It's not even about non-ID physicians who are also providing HIV care as their primary place of practice or the primary population they work with. We must broaden, and we must finally recognize and really appreciate and value that if we are going to reach our EHE goals, that we got to get everybody. We need people living with HIV on board. We need to create jobs for people living with HIV who can help guide us, who have trust and accessibility and knowledge that perhaps some of us don't have. We need to also think more broadly about primary care providers and adopt a model where some of us will be specialty providers and care for large volumes of people living with HIV. But every single provider needs to have enough competency that if they do have a person who is either potentially at risk or is living with HIV, that they will be able to initiate treatment. We need to think about registered nurses, licensed practical nurses, nursing assistants, pharmacists, dentists, social workers, behavioral mental health professionals, community health workers, and the list goes on. We must leverage the entire health and public health workforce if we're going to achieve the EHE goals. And one more sort of point here. You know, I realize that we're at an HIV conference, but these things co-occur. The kinds of health inequities that we see, it's not just HIV. HIV is a terrific example of how, as a world, we've come together to try to respond. But we need to do that across a number of areas. And the only way we're going to do that is by thinking about a reimagined workforce. And one thing that I'm super proud of, that I hope that we all are proud of, is that HIV has been the example. HIV has really led in terms of showing our country and the world how we can come together and do this. We got to do more of it. We got to do more of it. So in terms of broadening our definitions, you can see the sheer size. People are often surprised by this, not in this room, but when I show people that are not nurses that we are focusing a lot of the discussion on roughly 4,000 people, and we're talking about ending the HIV epidemic in our country, when we've got a workforce that, if we really look across, we have so many more actors that we need to engage. And so look at the registered nurse workforce, the massive giant that has the ability to actually have a huge impact in terms of health inequities. We should have our rightful place at really leading in terms of our national response. And we need to elevate our voices to do that. Look at LPNs, look at MPs. If you put us all together, more than 4 million. But let's not leave behind our friends who are social workers. That's where I started my career, by the way. I was a licensed clinical social worker before I became an NP. So I love social workers. I love behavioral health and mental health counselors. Love my pharmacists. I love all these guys. Together, we can provide better care to the people who we're serving. And we need to start thinking that way and stop focusing on just the 4,000 that you see in the upper left. So that's what this new model looks like. Strategy 2, we need a team-based approach. It's no longer about the physician at the center of things, sort of delegating and sort of guiding the team. It's really about a team working together in ways that are culturally competent, responsive, and aligned with the communities that we're serving. And we together collectively offer complementary skills. One is not better than the other. We are all essential in terms of our response. And that's what we need to start teaching people, how we can work together and actually end the epidemic in our country. A new resource, which is not so new, but it's about Latinos and something that we recorded about cultural competence. If anyone wants to kind of get a sense of, well, what does that mean from a Latino perspective within an HIV context, there's some great free sort of resources that you can sort of check out and hear about culturally appropriate care within the context of HIV. It focuses on Puerto Ricans, but it's broader. It can actually apply to other Latino groups as well. So I think the data is clear. Ryan White is sort of the best example. When we have a multidisciplinary approach, wraparound services, comprehensive care, we achieve greater viral suppression. And so you can see here what gets reported often. So Ryan White patients receive much better clinical outcomes relative to the national average. What doesn't get reported as much, and if you think about where I started earlier, was the aging population. So that indicates, in my mind at least, that Medicare and the Medicare program will be at play. And when you think about other public payer programs, Medicaid, we often don't talk about those two programs. I think if we showed the data for Medicare and Medicaid, it would not look like Ryan White. Actually, I'm certain of that. And so I think we've got to think about the fact that people living with HIV are getting older. It's time now for programs like Medicare and Medicaid to make some changes and to start getting prepared to replicate some of the terrific lessons that we've learned from Ryan White. Scope of practice. We often talk about NPs. It's not just NPs. It's PAs, it's pharmacists, it's other disciplines. And so what you see on the left is that depending upon where you live, your state will have more or less regulations about your practice. Very disappointing for me. I was living my entire life in New York State. I was working at NYU and at Montefiore Medical Center at the Adolescent AIDS Program. I had tremendous ability to do things for young people. I moved to North Carolina, where I'm now at Duke. I'm working at the Durham Department of Health, the Early Intervention Clinic downtown, and I'm in a red state in terms of scope of practice. And each time I think that I can do something, I find out that I actually can't and that I need to get someone else, typically a physician, to approve that. It's really frustrating, and it's really stopping the care to people who need the care. And what's so troublesome about that is I thought, being in the Bronx, that the kinds of contexts in which the young people that I cared for were living in, that was challenging. It is challenging. But when I landed in North Carolina, and I now understand a little bit in this past year and a half what the patients in our EI clinic are facing, rural patients coming very far distances, New York City is like landing in a utopia compared to what we're dealing with in North Carolina. No offense, guys, but it is really, really challenging in terms of being able to provide the care. And the state doesn't help us based on regulations and the kinds of things that we can do. The same is true of PAs, and the same is true of pharmacists. There's variation. What we need is a reimagined model that allows all healthcare providers to practice at the highest level of their competencies, their training, and their education. We're not asking for an increase in our scope of practice. We're asking to be allowed to practice consistent with our competencies, our license, and our education. Big distinction, because often the argument becomes about expansion of scope. We're just asking to do what we've been trained to do. Here's some reasons for removing practice restrictions. The National Academies of Science, Engineering, and Medicine, great report that was focused on primary care. 70% of the primary care shortages in our country would decrease if we actually allowed NPs to have full practice authority. You can see in the bottom in the middle that 50% more likely PAs and NPs to prescribe PrEP relative to their physician counterparts. You can see that the care, we know this, there's 50 plus years of data that shows that the care that is provided by nurse practitioners and PAs is comparable within this areas of specialization, and yet much of the rhetoric is about safety and quality and how somehow having a PA or an NP is less than. That's simply not true. The evidence doesn't support that. We know that pharmacists are increasingly doing terrific things. There's some great evidence that has been published in papers that I've been reading. There's some great states like California that are really piloting these innovative ways of having PrEP and PEP offered in pharmacies. And I think that as time progresses, that there will be more retail pharmacies that are going to adopt this approach, and that we'll start seeing that these services, just like our influenza and our COVID shots, that the pharmacies are going to start offering things that are going to make HIV prevention much more accessible. I think that's terrific. Strategy 4, adopting a decentralized and differentiated model. You know, we have had for a long time one size fits all. We've sort of required in many settings that people needed to come at a certain cadence, that they had to do certain things at certain intervals, that it required the brick and mortar sort of clinic structure. We've got to reimagine that. We learned from COVID that everything we said we couldn't do. I was one of those people. No, we can't do a telephone visit. No, we can't do telehealth. I need to see that adolescent in my office. Well, it turns out that when we were pushed to do it, we did it. Surprise, surprise. We got some positive outcomes. It worked, and people actually responded well. We need to reimagine beyond telehealth all the ways that we can move the locus of care to where people in need actually are, and where they need our services the most. And I think we need to be creative about that. We know that the linear approach is not true. It's not the case that if you come, a certain number of appointments and that you follow sort of a very scripted and very sort of everyone doing the same thing regimen, that results in better sort of outcomes. We can differentiate. There are some people in clinic who are outliving their lives, they're working, they're in school, they're forming relationships, they're starting families. They don't need to be bogged down by all of the requirements of that particular clinic, right, or the funder. They should be able to access care based on what their life is and what their needs are, and it should align with how well they're doing. And there are other people that need enhanced services because maybe they're not doing as well. And we need to start thinking about things differently. What we provide, when we provide it to who and where. And all of those things represent opportunities for us to be innovative and to achieve our EHE goals. We need to stop describing Strategy number 5, social determinants of health in a static way. It's terrific that we now know that poverty and housing instability and these large-scale factors are shaping negative health outcomes. But we got to do more than just describe them. We don't need to continue to tell stories of deficiency. We've got to think about what are the specific pathways or processes that are shaping that negative outcome. How does that housing instability, how does that poverty really shape the thing that we're committed to changing, and for our purposes, the HIV outcome? And if we can identify those pathways, then can we potentially more effectively mitigate and not simply check it off in our EMR and say that they're having food scarcity and somehow we've done our job. That is not acceptable. And so we got to train our workforce to do that. I'm really proud. Now I'm officially bragging, guys, about Duke. So give me a second. I promise it'll just be 1 second. So at Duke, we've been working really hard. We're about to launch something called the Doosan Trailblazer. Doosan is the Duke University School of Nursing, and we've reimagined what effective mitigation of social determinants of health, what that looks like. We've got a new framework and some principles. And if you take that little code, I'm going to leave it up there for a second, you will be on the list. And when we blast Doosan Trailblazer, you will receive it. It has a bunch of tools and resources. It has animation. It has a lecture. It explains how we can do this differently. And we're super, super proud of that. And I hope that the nursing community here, ANAC, will support us by passing it along and just sharing it with other people. So thank you. My final slide, and then I'm going to take some Q&A and see what you guys are thinking. So here are some recommendations, and these are more for our policymakers in the room and for folks that are working in places where they can lift their voices and be heard. We need to remove regulatory barriers. I think this is really important. All healthcare providers should practice at the highest level of their training, their license, their competencies. We need to ensure that CMS offers reimbursement for our decentralized services. We shouldn't have any subtle, as Dr. Farley said yesterday, subtle suggestions that we provide care face-to-face because it's more economically beneficial to have somebody come in. And so we've got to make sure that reimbursement for decentralized, differentiated, and team-based whole person care is actually part of how we're actually supporting, from a payer point of view, healthcare delivery. We've got to really shift our education. I think I've expressed today my view of what needs to happen in terms of nursing and clinical education. Much greater emphasis on training our workforce to respond to those large-scale events and how that shapes the clinical work that we do. We need funding for HIV training programs, both in terms of nursing, but also medicine, pharmacy, social work, all the disciplines. We need to focus that care on team-based and, again, whole person care, and that should be the training model. It should not be when you graduate, that's the first time that you're really working closely with members of an interprofessional team. Schools of nursing and other schools, other health profession schools, should be teaching students alongside with other disciplines. We need infrastructure to develop our decentralized and differentiated care, and this has to do with things like some of the work in pharmacies or in community-based settings, or ways to better support what's being called a non-expert workforce. So people who are not like us, who are members of ANAC and who have defined our careers as being in the HIV space, but what about our colleagues who are working with people who have other kinds of chronic conditions, but yet they encounter somebody with HIV? We've got to support them as well because they're part of our workforce. And we need to have some demonstration projects. This is my plug for research. And demonstration projects are really about nurse-led models that we can evaluate and that we can show can be scaled up nationally to mitigate the harmful SDOH determinants, and that will really bolster people being resilient in spite of the adversity that we're all facing. I think these are things that we should adopt, and for me, they represent a way forward. So thank you very much. I hope that was interesting, and it was great having the chance to talk to you. Thank you. Thanks. Thank you. Thank you. Thank you. Thank you. Thank you. You're going to make me cry, nurses. Any questions or comments or anything anybody would like to share? Yes.
Yes, we're look at all of us standing in line. We want to respond. I want to thank you so much for your presentation. My name is Carol Dawson-Rose. I'm a member of the ANAC Golden Gate chapter in San Francisco, California, and I just want to clarify for everybody that we have a master's and a doctoral program in our School of Nursing that has been consistently running for 30 years. And so we're training NPs in every type we have. We're training PhDs, we're training community public health nurses. So I just wanted to put that out in the air that it's not only Duke,
Sure.
but we're still there in San Francisco.
Thanks, Carol. I stand
Thank
corrected.
you.
I'm happy. Hopefully I've been wrong about other schools, because truth be told, I want other schools to think about this, and so it would be great. Yes.
Hi, Vincent. I'm from, from Rutgers University. First off, he did me proud, so thank you. And I also ran the nurse practitioner program that was HIV that was shut down, sad to say. And so we've been beating our heads, like in academia, to get the HIV content out. And I think, is there one thing that you can tell to this group of, we're here, we're ready to do it. What is it that we can do? One thing, a lot of good stuff, but one thing that we could take back to change that mindset.
So in my view, I think that more of us need to get involved in advocacy and policy and be willing to really message on the importance of the nursing workforce. Too much, recently, I won't mention the school, but a school that I'm affiliated with, there was a New York Times reporter that came and she was asked a tough question. And the question was, well, why does the news keep on reporting these negative stories about nurses? And she said, it's not about reporters or the media. We only depict what society perceives and represents. And the best way to change that is by nurses elevating our individual voices about what our profession truly is and our contributions. So the one thing I would say is get involved. Write op-eds, speak out, go to those meetings, be really clear about whatever it is that you believe as a nurse, and identify yourself as a nurse and be proud of that. By the way, shout out for Sue Willard. Sue Willard was my preceptor when I was becoming an HIV nurse practitioner. She's fantastic. This side.
Hi, Michelle Crespo-Fierro, Greater New York chapter. Still at NYU, I stayed. I wanted to bring up a couple of things, one of which is getting back to this theme here about, training and education in HIV care. I think that one piece that was missing, and I wish I could have heard more about, we need to do this work at the undergraduate level.
Yes.
That's where we hook them in. So that's number one, and I will say Hunter College, Hunter Bellevue School of Nursing in New York City, I did the subspecialty in HIV as a clinical nurse specialist. So I want to, again, the other APRNs also want to emphasize that as well.
Yes.
The other thing I want to say is ANAC was founded by RNs, nurses, let me extract the RN, nurses involved in the care of individuals when we did not have medications to throw at them, when medications were starting to be thrown at them and we were saying, no, you can't just do that. We were talking about social determinants of health back then. And, I love my nurse practitioner brothers and sisters here and siblings, but there was a shift. And those of us who don't have NP after our name, we kind of got put over to the side. And now that interprofessional practice, oh, what a concept, it's coming back. But, I think we should say, you were doing it, you have been doing it, please show us, let's listen to you more about how to do this so we can achieve our goal of ending the epidemic. And I'll stop there. Thank you.
Great point.
And
what was that? Oh. So I definitely agree with what Michelle was saying, just really quickly, because I want to make sure that I can agree, and I can also say that when I think about nationally our sort of morbidity mortality data as a whole, and this is not just nursing, it's all of us, I don't think that we've done a good job. I think that things are getting worse, not better. And so I think we should pay attention to that, and it's definitely important. And it doesn't mean that I don't agree, it just means that I'm looking also at data nationally. Too many people sick and too many people dying prematurely. This side and this side, yeah.
Hi, thank you. This is so much what I needed to hear, and I think what we all needed to hear, just really refocusing and being practical about where we need to go. So thank you for that. Marique Moan, University of Maryland, Baltimore, Chesapeake chapter. Two kind of structural things that I would like to see addressed is one within education. Where does this show up on the NCLEX? And then when you're trying to infuse social determinants of health into the curriculum, there's a lot of pushback because how do we devote time to that? We all know that it accounts for 80% of everybody's health, but when it isn't counted or represented in those metrics, and then trying to get nurses into community practicums for placements outside of the med-surg acute care setting, you hit those ceilings all the time. So we don't really have sustainable pathways to get nurses to be exposed to outpatient community care because we're just pushed back at every point. And then in payment models, if we want to have this less hierarchical structures, the reimbursement, nurses aren't represented in that, promoters aren't represented in that. We need structural changes as well. Thank you.
Totally agree. Ditto, ditto, ditto. This side.
Hey, Dr. Ramos, good to see you.
Good to see you too.
I'm Andrew Yu, and I work for the Indian Health Service. So I think it's really important, and you did in your speech, that the challenges of recruiting talent in rural and frontier communities are even greater than our urban and suburban partners. I can speak on the behalf of Indian country. We rely heavily on locums because people will only stay 2 to 3 years until their loans are forgiven, and then they go back to their urban and suburban environments. So I think it's key that we start educating our youth very early in these rural communities that a career in health sciences is viable, and to provide that support not only financially but professionally once they do make that decision. So I just wanted to make that point.
Thank you. Thank you so much, Andrew, for that comment. I hope that next year, Andrew, that you will be doing a plenary on Native American Indigenous communities. I think you should bring that to us. We need it. We definitely need it. Thank you.
Yeah. And then a quick plug. So we talked about NHAS on World AIDS Day. IHS will be releasing the indigenous version of the HIV/AIDS strategy. So just look out for that as well.
Wonderful. Wonderful.
Yeah.
Vincent, my name is John Nelson, and I am at Rutgers University. Incredible, as always. Just a couple of things. One is, as an update for the HIV workforce study by HRSA, that was published in 2016, that was done 2010 to 2012. I think they collected the data in the early part of that decade. We've repeated it at the NCRC, and it will be published soon. We have found a 10% decrease in physicians, advanced practice nurses, and PAs in the next 5 years. And it happens after 45 years old. There's a direct drop all the way down. It doesn't go until 60 or 62 and then drop. It starts earlier. There's a lot of burnout. There's a lot of non-support from all the things that have been mentioned, as we know, and it's critical. The other thing that it's a pet peeve of mine is that the EHE, in the HIV epidemic of new infections, and that means less than 3,000 in 2030. It's not eliminating HIV. Yes, we need a cure, but we have millions of people all over the world living with HIV, and it's not going to end in 2030. And the reason I'm upset about this is there were residents and fellows who wrote they don't plan on doing HIV because of EHE. It's not going to be a thing of the future. And so the only category, so now you don't have to read the article, the only category that was predictive of staying in was being a family practice physician. So it's no longer ID, internal medicine, it's primary care. And we had a small response from FMPs, but we clumped FMPs and family practice providers together because they're doing the same work. So it's really important that all of these strategies that Vincent is mentioning are utilized and taken up across the country. But we seriously, HIV is going to be a part of everybody's lives sitting in this room until after we've gone. It's not ending, but it so sounds like ending the epidemic, but it's the new infections we're trying to get down to below 3,000, and we're still failing at that. So thank you.
Great point,
You do
John.
great point.
I have a question, though, for you, John. So I understood, and I'm not as close to the data as you are, but I understood that the FNP data in the new HRSA study, that it didn't look promising, that young female FNPs were choosing HIV as a specialty, but I don't know if that's true. I saw a presentation that was preliminary data.
Yeah, no, our overall NP response was pretty low.
Okay.
But it was primarily the postgraduate training that was statistically significant for staying in HIV care was doing a family practice residency. And that was the only significant. The other good thing was that if you were younger and identified as being Black, you were significantly more likely to remain in HIV care.
Wow.
So those were the main. Age was the biggest factor, but it wasn't at 65. It was 20 years before that.
Yep. Thank you. Thank you very much.
Thank you.
On this side, Carol.
Hi. So I just want to piggyback a little bit on when the question was, what is one thing that nurses can do? And Vincent answered by saying getting involved in advocacy. On our pre-conference day was a workshop, a skills building workshop on nurses involved and other healthcare members were involved in advocacy. On Monday, first of all, you're all ANAC members, whether you are longstanding or this is your first conference. By being at the conference, you are now an ANAC member. And so on Monday, you're all going to get an email that outlines some of the steps that nurses and other healthcare team members can take in advocacy. And included in that is a link to an advocacy toolkit that we developed for the workshop. And it has everything from something that you can do as a one-on-one individual to in your family or in your social network to how to meet with members of Congress. So it's that whole range of activities that nurses can get involved in. And it's also going to be downloadable on the ANAC website too. So back up to that, some tools and skills to how to do this, right?
Thank you.
I just wanted to make an announcement. We have about 5 more minutes, so maybe these last 3 people. And then, yeah.
Sure.
Yes.
Yeah. Okay. No, thanks. Thank you for your presentation. It was very comprehensive. And I appreciated all of the elements you presented. I'm Laura Tyson, by the way. I'm with the President's Emergency Plan for AIDS Relief.
Hi, Laura.
A lot of what you presented is not new, as I'm sure you're aware. It has been going on in especially countries in sub-Saharan Africa and some countries in Asia for years. So I was wondering if there had been any thought given to reaching out to some of these stakeholders to really learn from them. Because like I said, a lot of what you said is not new.
Sure. So I guess what I would say is that my focus today was on the U.S., but I do realize that in the PEPFAR context, that countries like Botswana and other countries have achieved their targets, and there's tons that we could learn. And there's lots of, sort of lessons that we could probably apply to our own epidemic nationally. I think many of the points are still valid, and I agree. I agree, absolutely.
Yeah. Well, just so you know,
Yeah.
you have a very talented team. Can the South African group stand up really quick? Can you guys stand up from South Africa? Just so he can come speak to you after this. Yeah. You have the chief nursing officer amongst that delegation from the Department of Health for the whole country. So I would really encourage you to reach out because it's so wonderful to hear this applied in the U.S. context. But I think it's always important not to reinvent the wheel when other lessons can be learned.
What I would say, though, I would direct that to our group, and that our group should reach out, and there should be lots of synergy between folks that are practicing globally and also here in the U.S. So thank you.
Absolutely.
Thank you very much.
Yep.
Thank you. Yes.
Hello, my name is Christopher Hetzer, and I work at a pediatrics clinic in a nationwide children's hospital. And my question to you is, what communications would you recommend on reaching young adults and teenagers who need to hear about the sexual disadvantages and risk behaviors? That was all worded weird.
Great question. So I think I could probably spend a long time, Christopher, answering that question because that's actually what my research is focused on. For me, I think that we've got to target young people, particularly young MSM, but young people broadly, especially those that are residing in contexts where there's high HIV prevalence. My approach has been really building on the important role of families, and I do a lot of work that has been targeted on how to get parents, however we define parents, biological, non-biological, talking about these issues with their adolescent children. I think there's some folks in the room like John Nelson, who's like I think a fantastic pediatric NP who's been for decades working on these issues. I would encourage you to talk to him and then grab me too, Christopher, and I'm happy to share with you a couple of resources. One is there's a publication that my group did in something called NAM Perspectives, and so the National Academies of Medicine Perspectives, and it's entitled Shifting the Paradigm, and it's all about youth and strategies for better engaging youth and specific things that can be done. And so I'll send that to you, and we can talk after I get off the stage. Okay. Yes.
Hi, Jan Stockton from Midwest AIDS Training and Education Center, MITEC, at the University of Cincinnati. I'm sure that there are people that I didn't get a chance to talk with about my poster, P28, that looked at incorporating components of the National HIV curriculum into, well, in our situation, it was a nursing education program, specifically at the graduate level. It was a project that was funded by HRSA. We just completed the 4 years. Really found that we were able to successfully work with faculty in colleges of medicine, nursing, and pharmacy, where they may not necessarily have been experts in HIV, but they could take pieces of the National HIV curriculum and incorporate it into their course so that the students got the content. They were able to take the quiz at the end. Faculty were able to assess the fact that they had learned something. At UC, we did it in 4 different core courses in our NP program. Faculty loved it, students loved it, and we looked good at the end. So anyway, MATEC has gotten funded to do a round 2, but they're going to expand outside of the Midwest region, so any college of nursing can apply to participate in this in round 2. So if you are on faculty someplace or know people who are on faculty someplace where you'd like to see this happening and you would like some money to do it, you can take a look at my poster. It's P28. I believe that my contact information is in the speakers list. Let me know. I will be happy to send you a PDF copy of the faculty manual so that you can get a little bit more sense of how we did it. And then also some information on how you would contact Caleb at MATEC if your institution would be interested in applying for the funding. So that might be one way that we can work together to help educate the next generation of nurses and nurse practitioners. And by the way, I too am an HIV clinical nurse specialist. So,
last comment or question. I think we have to wrap up.
Great, thank you. My name is Sandra Laframboise. I'm from Vancouver, British Columbia. I'm a psychiatric nurse by trade, and I'm also a researcher, but I'm a community outreach member and an elder, as an Indigenous elder. One of the things that I see all the time, and I'm going to challenge everybody in here, because while this is a professional nursing association, the biggest workforce is our peers in HIV and AIDS. They get unpaid work a lot of times. And the other second biggest workforce is the volunteers who addresses social determinants of health. So I am sad that I'm sitting in this beautiful professional people who care, that we don't put peers in education and that we don't develop a program and that it is left to the community NGOs to train the peers to provide determinant of health social outreach. And so when you develop your program, please think about that, because we are doing research and we're implementing education for peers and what it means and how they can be professional peers in community, because we need them.
Thank you. Thank you very much. Important comments. Thank you, guys. I appreciate it. Thank you.
All right. If we can give Dr. Ramos another round of applause, I think that was an awesome presentation. And we can all leave here reinvigorated and ready to get started to work. I have an announcement. Unfortunately, our closing plenary speaker, Dr. Dawes, tested positive for COVID, so he can't come. So we're going to move up the we're going to put it, update, the monkeypox session will be at 3:45 in this room instead of the closing plenary. Yes, but we'll get him back. He'll be here again, so don't worry about it. All right. So the exhibit hall is open, so make your way to the exhibit hall. And of course, Dr. Ramos is here if you have any questions for him. What happened? Oh, no, in the exhibit hall.